my twin brother, Muruti, if you permit, if I can ask my twin brother, Tsepo, to open in prayer for us. Tsepo, can you open in prayer for us?
Okay, gentlemen, can we close our eyes in prayer? Our kind and gracious Heavenly Father, Lord, we'd like to thank you for the opportunity of life that you've given unto us. Thank you, Lord, for the opportunity that you've given us as men to come and discuss issues that will be of benefit to our health. And as our health improves, let our relationship also improve better with you. We ask you, Lord, to be with us as we listen attentively and be with the presenters as they are presenting. May your Holy Spirit never leave them. In Jesus' name we pray and we thank you. Amen.
Amen. Thank you very much, gentlemen. Like I've said, we are trying to create this as a safe space. Let us talk, and we know that whatever we talk here ends here. Oh, the doctor is in. The doctor is in. The doctor is in. Wow, thank you. And in fact, let me then take this opportunity as well to welcome Dr. Butau. Tawanda is a very old friend of mine. In fact, he was here in Cape Town. I know him very well as well. He was still here in Cape Town. I've been to his house here in Cape Town. I've been to his house in PE. He is born and raised in Harare, Zimbabwe, undergraduate studies at the University of Transkei, and qualified as a doctor in 2003. So we are not dealing with an amateur. He qualified as a specialist physician in 2010, then specialized in cardiology at UCT. He qualified as a cardiologist in 2013. And I know you might be asking yourself, a cardiologist versus the topic of tonight when we're talking about prostate cancer, how are they related? But trust me, he's well versed in that field. And he's, like I said, he's not an amateur. He's not only starting now in his medical practice. He's married to one wife. A doctor also, Dr. Butau. So they are both doctors in the house, and he's a father to 3 children. So, doctor, with those words, we'd like to welcome you. And, please,
thank you very much.
Be at home. Thank you that finally we could get you in. Yeah, we're gonna hand over now to our pastor is gonna do the first presentation, and then you can also add, and then we can open it up for questions and assistance. And welcome, Zakele. I see you also there.
Well, thank you very much. I'm really excited about this opportunity to share with you. I would like to commend Langa Adventist Men for this initiative. Earlier in the year, Tsapiso and I got together and chatted about this and that, and about you know, a WhatsApp chat that the men have, and I was really encouraged because they interact with each other, they connect with each other, and they speak about things that they would normally not speak outside of that WhatsApp chat. And I was very pleased about that, because you see, what I saw developing there was they were creating a safe space where men could share freely. Now, I cannot speak authoritatively as someone who knows the culture, and so I would suffice to say that I am pleased to see the level of interaction, and this initiative, Conversations for Men, by men, or by men for men, was born out of that discussion that we had, and we felt that we needed to be real and relevant in dealing with real issues, and really, Tsapiso and your team, well done on this launch of our conversations by men for men. I know this is not planned, but I just want to share with you. In 2018, I was diagnosed with prostate cancer, and my life has changed significantly since then. but because the diagnosis was relatively early, I had nerve-sparing surgery, and I am here to tell the story. And I'm pleased that I have this opportunity, because it could have been so different had I not been proactive in having my prostate checked annually. So, I'm a survivor. Without further ado, thank you very much once more for joining us. As Tsapiso mentioned, we're going to have more discussions with men, more conversations later on. But so we're looking at the anatomy and function of the prostate. And so we will be talking about what is prostate cancer, how common is it in South Africa, how is prostate cancer diagnosed, symptoms of prostate cancer, other diseases of the prostate, how is prostate cancer detected and diagnosed, what is prostate specific antigen or PSA, anatomical discussion which the doctor will engage in, medical perspective which Dr. Tawanda will deal with, and then we'll have another testimony and questions. So without further ado, what is the prostate? Well, the prostate is a male sex organ affected by a number of hormones, in particular testosterone and adrenaline. As you can see there, 95% of the testosterone is produced by the testes, and the adrenal gland produces 5% of the hormones. And so we will also just look at a cross-section of the prostate later on, and we will see exactly where it is situated. So hormones stimulate the activity of the prostate and replace worn-out prostate cells.
Was in the 12.
As mentioned earlier, the prostate is a major sex organ together with the testes and seminal vesicles. These glands secrete the fluids that make up sperm or semen. The prostate plays a major role in reproduction. And it is the size of a walnut located just below the urinary bladder. It surrounds the upper part of the urethra, which carries the urine and semen to the penis. So this is the prostate. Now I want to just talk about how common prostate cancer is in South Africa. I must just add, before I continue, that the stats are not readily available. So we will look at African American men of African descent, and this will help us to set a sort of a benchmark for the discussion. So there are no reliable statistics, but prostate cancer is the leading cause of death in 46 countries, including sub-Saharan Africa and the Caribbean. When I went for my prostate test, the two doctors that I was consulting with said to me, no man has to die as a result of prostate cancer. And that was very startling for me. So race is a proven risk factor among African American and Jamaican men of African descent. So the reason why this is the case is because the highest recorded rate of prostate cancer worldwide is recorded amongst African American and Jamaican men of African descent, and that's frightening. That's frightening, considering our audience this evening. In 2018 to 2012, stats indicate that African American men had a 70% higher risk than their white counterparts, and so that is a statistic that we need to take seriously. This statistic startled me. African American men diagnosed earlier than South African men of African descent. And the consequence of that is very often the majority of South African men of African descent will only be diagnosed when the cancer has spread. And this is called metastatic prostate cancer. And take note of the last three words there. When the prostate cancer is diagnosed too late, it is incurable. Otherwise, it is curable. And this was very interesting also. Prostate cancer may be genetic. In other words, if there's prostate cancer in the family, there's a large opportunity or a big opportunity or a bigger chance or a greater risk of contracting or getting prostate cancer. And then also breast cancer in the family also renders men at risk. So how is the prostate diagnosed? The cause, first of all, of the prostate or prostate cancer is unknown. And let me just add, this is not my own presentation. I've taken it from research. So just bear that in mind. Cancer and normal cells in prostate are stimulated by hormones, and we spoke about testosterone and adrenaline. It is one of the relatively slowly growing cancers. That's prostate cancer. It grows relatively slowly. Prostate cancer is rarely seen in men younger than 50 years of age. So if you're younger than 50 years of age, then you fall into this category, but don't sign off now, just stay with us. The incidence increases steeply between the ages of 60 and 80 years. So those of us who are 60 and above are more at risk of developing prostate cancer. More than 70% of cases are diagnosed in men older than 65. Well, when it was diagnosed, in my case, I was 56 years old. 56 years old. And that was relatively early. So the symptoms of prostate cancer, it causes a restriction of the urethra. In other words, you have difficulty urinating or your urination stream is weak. And these are the first symptoms of prostate cancer. There's frequent urination, especially at night, because the bladder is not empty. And so you feel this need to urinate, or the urge to urinate. Another symptom is blood in your urination. So it does not necessarily mean that when you have difficulty in urinating, that is cancerous. It may be for another reason. So don't be alarmed that you have difficulty in urinating, and then it automatically means that you have cancer. That's not the case. So with or without symptoms growing, cancer cells can spread to other organs. So if the prostate cancer is detected early, we avoid the spread to other organs, and the spread of cancer is the most common pain is bone pain. So other diseases of the prostate, benign prostate hyperplasia or BPH is an enlarged prostate, generally in men over the age of 45. Is 8 out of 10 men will develop this by the age of 80. So 8 out of 10 men will develop an enlarged prostate by the age of 80. And that's a frightening statistic. But the good thing is, with the benign prostate hyperplasia, it is treatable. But early detection is important. Then we have prostatitis. Yeah, is a common disease that develops at any age. Prostatitis is a common disease that develops at any age. It is an infection or inflammation of the prostate gland caused by bacteria. But the good thing is, it's commonly treated through antibiotics. But once again, this is based on early detection. So how is prostate cancer detected and diagnosed? Here's a couple of things that I would like to share. So digital rectal examination, or DRE or DRE, together with prostate-specific antigen, which we will refer to as PSA later on. So digital rectal examination is the screening test that must be conducted annually for males 50 years and older. And I must tell you, I started testing for or screening for prostate when I was under 50 years old. And the reason why I had a prostate or prostatectomy is because it was detected as a routine screening process. So the history of prostate cancer in the family should start earlier than 50 years old with screening. It is recommended that men with a high risk should start screening at 45. So if you are 45 years old and you go for your annual checkup, ask them to screen you for prostate. Be proactive. Screening of a male with a life expectancy of 10 years may not be recommended. And this is really a discussion that you should have with your doctor. So furthermore, how prostate cancer is detected and diagnosed. So the digital rectal examination is a quick and safe screening technique. The doctor inserts a gloved, lubricated finger into the rectum, and I guess this is what we fear, to check the size and the shape of the prostate. The doctor examines for lumps that are hard or irregular. So as through the examination, the DRE or the DRE examination, the doctor examines for lumps that are hard or irregular. And small tumors located within the prostate are often not detectable during the digital rectal examination. And so if there's abnormality found in the DRA or the DRE, this will be confirmed by a biopsy. And we will get to the biopsy. So the DRE is a digital rectal examination. The prostate-specific antigen, or PSA, is a substance produced by normal and cancerous prostate cells. When the prostate cancer grows, the amount of the PSA in the blood increases. And so when I started going to the doctor, my PSA was around about 4, I think, or maybe 3. And it progressively went up to 4 and then 4.5. And based on that increase, the doctor recommended that I go for a biopsy. Look at the biopsy. So it's, you see, they recommend that men with a high PSA have a biopsy, and this will determine whether there's actually cancer present. we continue with the PSA. The normal range of the PSA, as I said, mine was 4, 3, 4, 4.5. The normal range of the PSA is between 0 and 4. And the doctor will just give us some if the test results exceed 10, a biopsy may be recommended. Borderline readings, mine was a borderline reading. It was between 4 and 10. And often there are borderline readings which are benign. Does not necessarily mean that cancer is present, but in my case, I had a borderline reading of just over 4, and there was it was not benign, it was malignant. And so benign prostate hyperplasia, which we've spoken about, and prostatitis may also cause an abnormal PSA. But remember, we said that these are treatable. So we're still talking about PSA. If PSA results are borderline high, but the DRE results, which is the rectal examination, are normal, the doctor may recommend a transrectal ultrasound, and that will be we'll refer to as a TRUS as we proceed. And then this test is so the doctor uses an instrument which tests the sound waves to detect abnormal areas of the prostate. If the results are normal, a deferred PSA test, in other words, so if the results of the transrectal ultrasound is normal, you would then have to take another PSA test later on, and if necessary, a biopsy may be needed. And so there are some age-specific PSA references. So if you're in a certain, if you're in a specific age range, and you fall out of that range, then you have to test for your abnormal PSA. So the age range, PSA reference range compares results of men in the same age group. So for me, I'll be 58 this year. So there's an age range for a 58-year-old male, and if there is a specific PSA reference for that age group, then it means if I fall within that reference or range, I am safe. Outside of that range means that I fall outside and I'm at the risk of prostate cancer. So if the PSA levels are high compared to the age group, there is a greater risk of prostate cancer. And so the prostate-specific antigen velocity, this just measures the speed of the increase and tracks the PSA levels over a period. It is useful, but is not used to diagnose prostate cancer. PSA levels rise periodically and is age-specific, but it does not necessarily mean that you have prostate cancer with a raised PSA level. High or low PSA does not mean that prostate cancer is present. Remember, we spoke about the hyperplasia and the prostatitis. It may render a high reading, but it does not necessarily mean that cancer is present. So along with the DRE, the results will provide more accurate information. So the PSA test, together with the rectal examination, will provide accurate information as far as the PSA is concerned. Now we get to the biopsy. So abnormal findings in the PSA or the DRE will necessitate a biopsy, which is the only way to diagnose cancer. And the biopsy is done by way of a transrectal ultrasound, and in this way the doctor gathers various tissue samples that are examined for cancer. Biopsy you will experience, like I did, there was blood in my bowel, and my bowel movements, semen and urine, but it generally clears after a few weeks. And so this is a section or a diagram of the prostate, and maybe I can ask Dr. Tawanda to come in at this point and just help us to understand what we are seeing here. Doctor.
Yes, no, thank you. Thank you for a very detailed introduction and for taking us this far in terms of the presentation. I don't know if can everyone hear me?
Yes.
Oh, fantastic. Okay.
Loud and clear.
So we will change over in the meantime I have a very brief presentation of 6 slides that I would like to share. And whilst we're changing over to that presentation, so please, if you would be so kind, I would like to spend a little bit of time explaining to everyone the concept of cancer, because I think the concept of cancer gets lost upon us, and I think it's important for us to appreciate what cancer is. So everybody's body consists of a basic unit called a cell, and each organ in your body has the ability or propensity to start producing an excessive amount of cells of the tissue. And the issue becomes that if I'm going to use I'll use a completely random organ and then move on to discussing the actual prostate gland. So let's take an easy organ to identify. The nose sits right on top of your face. And if the skin on top of your nose starts to grow uncontrollably, it will start to deform the shape of your nose. Understood? And then if those cells grow uncontrollably, they start to invade and destroy the normal tissue around your nose. So it destroys the shape of your nose. It starts to block the nostril. You can't breathe because it's blocking the normal passage that you should have there. And it's uncontrollable. So it grows unregulated and starts to produce compressive or destructive effects. That's what cancer is. Any tissue in your body that starts growing uncontrollably causes invasion of local tissue, obstruction, compression, and disruption of the normal function of what that organ is meant to do. The prostate, and if you can move on to my first slide, please. The prostate is an organ that sits just below the bladder. So because of its location, if it starts to enlarge, that little tube that runs in the middle of the prostate gland can become obstructed. And as you can see, the obvious complication is that urine that sits and is formed in the bladder and is supposed to pass through the urethra, that little tube that runs through the prostate gland out into the penis and outside, is how you then expel or pass urine out of the body when each time you go to the loo. If that gland starts to enlarge, it will compress that passage and will restrict flow out of the prostate, out of the bladder. So the symptoms make sense that you struggle to void or pass urine. You have to strain, push much harder than you normally need to expel the urine out of the bladder. So that's the first and most common symptom of obstructive symptoms that people will develop when they have prostate enlargement. So I'm going to start off by talking about enlargement. The enlargement may be just from the gland enlarging and not actually being cancer, and we call that benign prostatic hypertrophy, but it can also be due to cancer. Then it's important that when if you're fortunate enough to start getting those symptoms and they start causing compressive effects, you will get symptoms, and it's about seeking medical help nice and early once you identify the symptoms. And if you can move to my next slide, please. The symptoms are very straightforward. They're all compressive. They're all very straightforward to recognize. It's about difficulty in passing urine, frequent getting up at night to go and pass urine because you're unable to completely empty the bladder, there's an obstruction to flow. You get a sensation of, even though you've gone, you've strained, you've pushed very hard, you've tried to empty the bladder, you still feel as if, gee, I try to pee everything out, but it's, there's still something stuck and left in the bladder. And when there's a significant amount of urine that's left over in the bladder, it starts to cause burning because you then get infection in the bladder from all that excessive urine. And when it's at quite an advanced stage, you will start getting blood each time you pee and pass urine in the blood. The worst symptom, and you've kind of delayed seeking medical help if you get to a point where you find yourself with complete urine retention. So you strain and strain and strain, you can't pass any urine, it gets stuck, and then it becomes painful and uncomfortable because there's a complete obstruction now. You get acute urinary retention, and this is one of the really, really uncomfortable sensations you can end up with. Next slide, please. So the diagnosis of the enlargement of the prostate depends on you as the man, the male, admitting that there's a problem. I don't know what it is about the male species as compared to the women that it takes us running into serious trouble before you actually will admit that there's a problem, and you will present yourself to your GP or a urologist if you're lucky, and then we recognize that there's an actual problem. And then the physical examination, as Pastor has already explained, involves a digital rectal examination. It is a bit intrusive, it's invasive, but my counter to this is that the other examinations that you present for require a stethoscope or the doctor touching your physical chest or back or whatever organ. Is it such an intrusive and unpleasant thing for you to have an examination that could potentially save you from a cancer, a life-threatening disorder such as a cancer? I think not. And this is the message we're trying to convey to us as males, to say, listen, if you're getting the symptoms, you're getting the pattern of symptoms that I've just described, it's better for you to seek help early rather than late, because you can actually get medical help. And you don't end up being picked up with cancer at a stage where there's not much we can do for you when it's actually confirmed. We've already spoken about the PSA. The PSA is a straightforward blood test. It's like any other that you will do when you go to check for your cholesterol or your blood sugar. It's not a particularly difficult test, and it's very helpful when it's abnormal for us to guide further investigation. And it may actually be something that your GP can do when you go for a routine, what they call a routine medical exam. You're otherwise well, you're going for a general examination. And if you're older than 45, get your PSA done as part of the blood test that will be done to check what's going on. The pelvic ultrasound has been explained already, where there's a suspicion that the prostate is enlarged, so I'm not going to dwell too much on that. And then the prostate biopsy is for us to differentiate whether this is what we call a non-cancerous enlargement of the prostate, benign prostatic hyperplasia or hypertrophy, versus actual cancer, which has a far more sort of sinister prognosis or bad prognosis, if that is the case. My next slide, please. The treatment modalities I will not spend too much time on. There is surgery to surgically remove the prostate. This can be done these days through robotic surgery, where they don't have to actually cut you open. They just put a few things through the anterior tummy wall, and they can remove the prostate without too much of a fuss. Not every facility has the ability to do this. The commonest is an open prostatectomy, where they have to actually cut through the lower part of your tummy and remove the gland completely. It's very effective, and it is a curative procedure when this cancer is caught early. In other words, they remove the cancer, they remove it whole. There's no chemotherapy afterwards, and you're cured. This thing will never come back, because the source of the disorder, the source of the cancer, is removed completely. There's no prostate tissue left behind, and there is no possibility of you getting it again, provided it's caught early and removed in its entirety. I'll show you a picture next of what brachytherapy is. It's not something that's commonly offered, but it is an alternative. It's localized radiation therapy. I'll show you how it's done, and it's basically delivering radiation therapy directly into the prostate organ, and it kills off the cancer cells and it shrinks it. And sometimes this is done as a pre-procedure to removing the prostate, where the surgeon feels, the prostate is so significantly enlarged, it would be risky for it to be removed as big as it is. So they do this brachytherapy before. And in some cases, when this brachytherapy is done, it's done and it's a curative thing and nothing further needs to be done. The last option is where they found that the prostate cancer has spread beyond the prostate gland. Then there are things that can be done to sort of reduce the size of the tumor wherever it has been. The prostate organ, as Pastor has already explained, is sensitive to hormones. So if you give specific medications that block that sensitivity to hormones, it can actually slow down and reduce the rate of growth or spread of the cancer. But this is something that becomes an option only where surgery is no longer an option and we've missed the boat in terms of offering you a complete cure from the cancer. And in addition to this, there are medications available that can be used in conjunction with surgery to alleviate and improve the symptoms. Next slide, please. So this is a diagram to explain exactly what's done. On the left, this surgery or this procedure is done under general anesthetic. Something is inserted through the rectum where we pass stool through. They inject through ultrasound guidance these small little pellets that you see magnified on the image on the right that are implanted directly into the prostate gland. And these pellets have radioactive material, and they actually help to shrink a very enlarged prostate gland and make it easier for a surgeon to then remove it. And as I said, in some rare instances, just putting in these pellets, it shrinks the tumor to an extent that nothing further needs to be done. The symptoms of blockage or obstruction then get relieved and no operation is actually necessary. Next slide. This is an image of what's called a TURP, or transurethral resection of the prostate. This is the least invasive of the surgical procedures that can be done to treat prostate cancer. So all they do here is that where the prostate is enlarged and has compressed that tube that I've already explained to you, called the urethra, which allows urine to pass through to the outside, when that has been significantly compressed by an enlarged prostate, surgery can be done, and this is done under a general anesthetic, so it's not like you're in pain when they're doing the procedure, you're completely out of it. They pass this rather fancy device, and they scrape out the enlarged prostate through the mechanism that's shown over here, and they are able to create a much bigger and wider channel to relieve the symptoms of obstruction and allow you to pass urine freely again, whilst you're getting other treatment modalities or options to try and treat the cancer without it being completely removed. This is usually a treatment option where you have non-cancerous enlargement of the prostate, and this is very effective. You have this done once, you can pass urine again, and this in combination with medication provides complete relief where cancer is not an option. And I think there's one more slide, if I'm not mistaken. No, I think that's actually the last slide. Yeah, that's the very last slide. Yeah, so thank you very much for the slides episode. And I think my biggest message to the men out there is that there are very few cancers where we've confirmed once a biopsy is taken. A biopsy is taking a piece of tissue of whatever organ is affected. A biopsy is done, it shows and confirms that it's cancer. Then you still have an option to treat the cancer and cure it. I'm talking about completely get rid of it. The prostate is something that's unique. Women don't have prostates, men do. And it's the one organ where if this is caught early, you have symptoms, it's tested, it's diagnosed, and it can be removed, you can have complete cure. There's very few cancers we can cure. most cancers, like the cancer of the cervix in women, cancer of the breast, invariably, even after the tumor is removed, you must have chemo and radiation and all sorts of other procedures to ensure that the cancer is completely treated and gotten rid of. Prostate cancer is the one very, very curable, one of the few cancers we can actually cure. So it's important that you recognize the symptoms early. You seek medical attention when this presents. You don't wait until you are at the point where you can't pass urine at all before you seek medical attention. And this can be cured, completely cured. Very few cancers that we can say that about. So it's important that you recognize this. You are aware of the symptoms. Once you are older than 45, you have family history, you are obliged to have the PSA test, because your risk of getting this problem is very, very high. So seek medical attention early. It's not something to be ashamed of. I'll give personal testimony. I haven't had prostate cancer, but my dad has recently had to have prostate cancer surgery. And he sat with this for 2 years, 2 whole years in agony. And I don't understand to this day why he took so long, because he got the symptoms early. He saw a urologist and he was offered surgery, and he thought, no, he's going to go and think about it. The medication helped, but the concept of having this invasive procedure didn't appeal to him. And he only consented to having the operation earlier this year, almost 2 years later, after he developed such bad symptoms. He couldn't pee. He couldn't pee. He was in such agony, and it took him being in extreme pain before he actually let the rest of the family know that, guys, I'm in trouble and I need help. And the surgery was technically more difficult. Unfortunately, he hasn't come out unscathed. He's recovering much slower than we would expect, but he is recovering. And my message to you, if you hear nothing else, my dad is he's just turned 70 today. Actually, it's his birthday. And if you forget nothing else about what we've discussed today, it didn't need for him to come to a point where he was in physical agony before he sought medical help. This could have been sorted 18 months ago, much less complicated procedure, speed, much faster recovery. It didn't need to come to this. And he got symptoms early, got medical attention early, just chose, I'm not going to have this operation because, the implications to sexual dysfunction, which I'm not going to touch too much on. If anyone wants information with regards to that, we can touch on that. But, I'm talking about a cancer, a life-threatening illness that is potentially curable, that we drag our feet about as men because we don't want to admit that we have a problem. Let's not suffer in silence, gentlemen. Gone are the days where it's manly to suffer in silence and a painful thing. It's not necessary. We don't need to be in agony where we don't need to be. Let's seek medical attention early and get medical assistance where it's possible. And as I said, my last word, this is one of the few cancers where we can cure it. It's not often where you can cure cancer. There's no chemo, there's no additional things. It's one operation, the tumor gets removed in its entirety and you're cured. You never have the problem again. I think I'll stop there.
Okay, thanks a lot, Doc. I think now we heard from our first presenter and our second presenter, and I need also to welcome in our midst Dr. Mbanga, who also joined us. So he'll also join the panel in fielding the questions, or perhaps if he has any comment as well that he wants to add, feel free. I don't know, Dr. Msengane, do you also specialize in the medical field?
Except that my rooms are closed.
Oh, your rooms are closed, and we charge for consultations, right?
So I'm not taking any consultations.
Okay, gentlemen, let me open up for any comments or questions that you might have on this topic. We've got specialized people in this field who normally charge exuberant fees. We've got 2 doctors already here amongst us, so let's use them. Their charge will go to Pastor Arnold Alexander's church, and he will foot the bill. Okay, can I see any hands? Are there any hands that needs to be noted? Muruti.
There is a question here.
I see also Mluluegi's got a hand.
And Tato has a question as well. How does
okay, I see. There's also Dr. Msengan has got a hand.
Yeah.
Suza's got a hand. So for those 3 hands, anyone else? So it's Msuza, it's Dr. Msengana. Okay, let's take these 2 for now. In that order, Msuza, and then we go to Dr. Msengana.
All right, thank you. Good evening. Can you hear me?
Loud and clear.
Yes, loud and clear.
Okay. Thank you to the presentation, Kamfundisi, and my brother. We haven't seen you in a while. Good to see you.
Likewise.
Just one question in terms of the slides. Should I be worried if I experience just one of those symptoms? Or should there at least be a combination of 2 or more?
Look, if you have
I think the dog has disappeared.
Okay, I don't know what happened. He so much disappeared. I think Dr. Mbanga, field that question, please. I think as your friend, I can do that to you. Leander. Leander.
You must unmute.
Okay, he's back.
The
doctor is back. The doctor is back. Doctor, you can answer. Are you busy connecting? Leander, why are you quiet?
Hi, sorry, man.
Okay.
I'm not sure what happened there. So sorry. The bit I caught was that should he be worried if he develops even one of the symptoms? And depending on your age, if you're above 45 and you have even one of those symptoms, it's worthwhile going and having the digital rectal examination by your GP or your urologist, plus the PSA, because that helps to gauge, first and foremost, whether the prostate is enlarged, and secondly, if there's any concerns with regards to cancer. Because as I said, it may turn out to be just what I described earlier, benign prostatic hyperplasia or hypertrophy. The prostate is enlarged much more than usual, but it's not due to cancer. That still needs to be addressed. It may not be cancer, but it is a progressive thing. The BPH or benign prostatic hypertrophy is kinder because usually that can be treated with a tablet. It doesn't require any operative procedure. And that will sort out your symptoms for the foreseeable future. But it's about not waiting up until you have a complete sort of 2 or 3 symptoms plus the PSA before you seek medical help. If you have any of those symptoms we've described, it's worthwhile starting off and having a checkup either with your GP or your urologist.
Okay, thank you. Let's go to Doc, Vivi, and then we've got a question also in the chat by Tato that says, how does early detection and cure affect one's manhood? That is the erection, etc. So that's the other question. But let's give a doctor the question.
Thank you. Thank you, Tsepiso, and thank you for inviting me to this wonderful presentation. Thanks, Doc, for very, very clear and Pastor for very clearly set out a presentation. And it's if it wasn't for the clarity, one wouldn't even ask questions. But because it was so clear, I have a few questions to ask.
I'm glad. I'm very glad about that.
Doc, I often hear of the Gleason score. What is it, and what does it mean?
So,
okay.
Yes, yeah. Sorry, let me write all the questions down. Yes.
Yeah, the Gleason score. I've heard of it. I don't know what it means. Second thing, what would you recommend as a possible diet that men can follow, so that it can lower our risk of prostate cancer? And the last one, the very last one, I think you might have alluded to it, but let me ask it nonetheless. What are the possible side effects of prostate treatment, both in the short and long term?
Okay, I'll start with the Gleason score. The Gleason score is something that they can compile where you've presented with the symptoms we've described. You've been examined by a urologist who felt the prostate was enlarged, and he's gone on to do a biopsy. So there's a confirmation that this is prostate cancer based on the tissue that's been removed from your prostate and examined by a pathologist. So it's a confirmation that this is prostate cancer. And the score, it's based on how the cells are arranged, how abnormal they are, etc. Do they extend beyond the margin of a specific lobe? And it's a score where the lower the score, the less aggressive the tumor is, and the higher the score, the more aggressive the tumor is. So it's based on, they've now taken a biopsy or a small tissue sample from the prostate, and they're saying this is low grade, medium grade, or a high grade cancer. And it basically will inform the urologist as to how does he need to just remove the gland and stop at that, or remove the gland and then offer you chemotherapy afterwards, or remove the gland and offer surveillance and radiation therapy after that. So that's what the Gleason score is about. It's based on how aggressive the tumor is after they've taken a sample of it and confirmed that it's actually prostate cancer. With regards to diet, as a fellow Adventist, this is a question I am often confronted with. And it is the thing I struggle the most with, because we have some very false preconceived ideas that I must dispel. And I'm glad that it's come out from one of our members, that you must bear in mind that there are very few things with regards to any form of cancer where there's a direct cause and effect. So if I don't do X, Y, and Z, then I won't end up with this kind of cancer. The only thing I can say for sure with regards to that is if you don't smoke, then your chances of getting lung cancer are pretty low. But it's only a certain kind of lung cancer that you won't get. Everything else, living a healthy lifestyle, which I might add, as Adventists, we advocate anyway. We don't smoke, we don't drink. So those things are inherent in our faith. You don't have to do anything extra to actually supplement or change your diet to reduce your possibility of having prostate cancer. There's a lot to do with genetics in this. I'm going to have to start looking at my PSA quite early because my dad has got prostate problems. So, you know, it's the genes I was dealt. I'm a male, so I must look a little bit earlier than the average guy. If I had no family history of prostate problems, I could probably start at 50. I'm 42 this year. In 3 years' time, I must start checking my prostate and doing a PSA because of the genetic makeup. But there's nothing about what I eat that will reduce my possibility of having prostate cancer. And let me be very clear. There's associations, things that are associated with a reduction in prostate cancer. Many of you, and those of you who are married, will be very pleased to hear that frequent sexual contact with your wife seems to be very protective towards getting prostate cancer.
Amen.
So
Amen.
the reason It's a reason you can use with your spouse to say, listen, ma'am, the more this happens, the better. Okay? But there's nothing dietary-wise that you can do to reduce your possibility of having prostate cancer. Nothing. I hear cayenne pepper and drink this and drink that, but it's all very vague, very loose associations, but no direct cause and effect. And then lastly, side effects. The commonest cause, and this is where I'm going to hit home again and say, if you have early symptoms, you're starting to strain a lot when you're starting to pee, it's better for you to get to see your urologist early and get a prostate examiner, PSA, and if he says, look, this is prostate cancer, it needs to be removed, get the prostate removed. Because if it's early and the surgery is done where the cancer hasn't spread, it's not damaging the nerves that are responsible for sexual function, your chances of ending up with problems of incontinence, inability to control your own urine flow and holding your urine up until you can get to a bathroom, all of those problems are less likely to occur. And the thing we're most worried or concerned about is sexual dysfunction. All of that is far less likely to occur when it's detected early and the surgery is done early with a prostate gland that's not so enlarged. Then you are far less likely to have those side effects or complications of the surgery than where you hold up until literally you are at the point where you need to stand for 5 minutes straining and straining and straining before you can pass urine, which means probably the prostate is quite large by now, and the surgery is going to be technically more difficult. Case in point, I'm going to use the example of my dad. He's really struggling. It's made him very withdrawn. I'm sharing very personal stuff here because, as I said, this is my dad. He's very withdrawn because now he can't. In the first few weeks, it's better now, but in the first few weeks, he couldn't hold his own pee, and it was, he wouldn't even admit it to me that he was struggling with these things. But that was all as a consequence of him having an 18-month, a year and a half delay in him seeking surgical relief from the problem than if it had been done 18 months ago, where he probably would have had a far less traumatic outcome with this procedure. So whether or not you end up with side effects is actually a direct product as how early, as a direct result of how early you seek medical attention. So that's the take-home message here, that even if you have slight symptoms, better to go and be checked out and be told, no, the prostate is not enlarged, your PSA is negative, something else is responsible for this, it's not the prostate, and have that sort of reassurance, then say, oh, it's probably nothing, I'll wait until I'm passing blood before I seek medical attention. That's where the problem is.
Thank you, Doc. Thank you.
Okay. No, thank you. I just wanted to check from the chat. There's no other question that I've missed out. Or, Doc, did you touch on that question on how does early detection and cure affect one's manhood, erection?
Yes.
We did
Yes,
answer that one. Yeah, we did answer that one. Okay. That was a question from Tato. So Tato, your question has been answered. Are there any other hands before we, if not, then we can, we're gonna give to Elder Kota, who's one part of our committee members, to close in prayer for us. And before we close, Pastor is gonna have something to say as well. Yes.
Thank you. I just want to add to the conversation.
Okay.
So, when my prostate cancer was detected, I had a Gleason score of 6, and that's high.
Yeah.
That's the one thing, and so maybe coming from a financial background, what I would like to recommend is that, if you can afford to take a little bit of great disease cover, that covers you in the event of prostate cancer. And I am a living testimony to someone that my broker said to me years ago. He says, man, just take a little bit of cover. And, because my Gleason score was so high, I think I was stage 4 cancer. My insurance policy covered that. and I was really grateful for that that wisdom. And the other thing is, with regard to my personal situation, the cancer spread beyond the prostate capsule for me. It had just started spreading out of the capsule, and what has happened is I couldn't have nerve sparing surgery because of that. So I had to sacrifice one of the nerves, which means that you know, and I'm also sharing personal information here, which means that it has a negative impact on erections, because the body now, where there were two nerves, the body now has to function on one nerve, and so it must now learn how to function on one nerve, and there is a measure of erectile dysfunction in my case, which means that I have to take medication to assist with erectile dysfunction, but it's not a major issue. And then finally, the incontinence is a real problem, you know. But fortunately, early detection once again, and also the physiotherapy that one is given. I had to go for physiotherapy to help with the incontinence, and I must be honest. I must be honest that sometimes I think I'm a little fitted because I need to get to the bathroom sooner. I have to react quickly. I tell you also, you know, the incontinence becomes very real, very real. But I would like to close off before we end this presentation. I see there are a couple of more questions. As I was preparing for this presentation and thinking about myself, my mind went to Psalms 139:14, where the psalmist says, "I will praise you, for I am fearfully and wonderfully made. Marvelous are thy works, and that my soul knows very well."
Yes,
you know, and that is something that I believe, I embrace, because as Dr. Tawanda mentioned, we are fearfully and wonderfully made. The body can recover because God made it that way. And so while God has made us fearfully and wonderfully, it is our responsibility to be good stewards of our bodies. And that means to go, Mshuza, if there's only one symptom, go and have it checked out and have it confirmed, you know, and that is our responsibility. God's responsibility, he's done his work, but then he's also the great physician. So we just have to be good stewards of our bodies. Thank you.
Absolutely.
Wow.
Absolutely.
Thank you. Thank you, Muruti. Thank you, Muruti. Doc, sorry, man, I've got two questions. And then, Tatukota, can you hear me? Tatukota?
Oh.
Okay. After these two questions, Tatukota is one of our committee members. He will then take the opportunity to thank the two panelists that we have, and then close in prayer for us. Doc, we've got two questions on the chat. One is from Tato. Is there recommended frequency for conjugal provision to try and reduce the risk?
Very, very good question, my brother. No.
Yeah,
there is no recommended frequency, but generally, the more the better.
The more the merrier. Okay. Yeah. And then
I just to follow on from that, I always say, you know, we are all about the bigger picture, and it's important to emphasize that you know, we are so fearful about losing our, in quotes, manhood, the ability to perform sexually, that you forget the bigger picture, that you would rather preserve your ability to perform and face certain death in a year or year and a half's time than the possibility of some erectile dysfunction, possibility, not certainty, possibility of some erectile dysfunction if you have the surgery, but the certainty that you will then live out whatever full life you are meant to have that the Lord has provided for you in return. That concept has to be very, very crystal clear. You know, you would rather face certain death by not treating your prostate cancer than face the possibility of possible, not certain, possible erectile dysfunction. Let that sink into your head. I would rather face certain death with confirmed cancer than the possibility of having no further erections, but being around for my wife and children. I've got small kids. I'd like to be around to see them graduate, have their own spouses, get married, etc. If it means I sacrifice my sexual function because that's what I have to sacrifice, possibly, to be around and see them, I'd rather choose that. Let's make it that crystal clear, that simple and that basic, that the sexual function possible, not certain, it's not absolute, is a small price to pay, rather than the prospect of certain death. Because cancer does kill. Let's not make any bones about that.
Oh,
Cancer does kill. If untreated, you're a goner. 18, 24 months max, if you're lucky. But, you know, that's the bigger picture. And I think it's not often that it's put in those simple terms, that we are so concerned about our sexual function, our manhood, etc., that you don't look at the bigger picture. You know, we have dependents, we have spouses, we have kids that we need to raise. And the prospect of your spouse raising your family alone because you chose to preserve your sexual function, for me, seems a little bit selfish. Very selfish, gentlemen. Let's look at it in that crude perspective.
True. Thank you, Doctor. Then the last question is from Tsepo, there in Boxback. He's asking just one more question. How is the attitude towards the herbal traditional medicine versus Western medicine affecting a positive treatment outcome?
Sure. So again, we are guilty as Adventists that we would rather try and experience the natural remedies where there's proven therapy for this kind of cancer. There is a role for traditional medicine, herbs, etc., alongside proven medical therapy. And all I advise is that, you know, don't try and mix and match. Don't try and, you know, try both sides. Work with one. This is one disease entity where we know there is a tested and tried form of therapy. So why not go that avenue first before you dabble in the unknown? The biggest problem I have with traditional medicine, I'm not doubting that in certain instances it works. Look, we are faced with the coronavirus pandemic. There is no confirmed treatment for coronavirus. The specialists that are looking after patients can support your breathing, but I don't know what the constituents is. If it's going to help, I'm not going to knock it for coronavirus because we don't know anything that is proven, medically tested and works. We do have things that we know work for prostate cancer. So I wouldn't recommend it as first line for you to try the traditional or herbal therapies for something that we know we have things that work, have been tried and tested and have saved lives. I wouldn't go that route as a first step. And I think that's all I'm going to say on the issue.
No, thank you, Doc. Thank you, gentlemen, for joining us. I think I'll give over to Elder Kota, who's going to be issuing a word of thanks to our pastor, Pastor Arnold. I don't think he deserves any thanks, but he's always there for us, supporting us. And yeah, he's here, but Dr. Kota, over to you. And then the next session, gentlemen, we'll be looking into the economy as men. You know, we are in this pandemic, the COVID. How does it affect our pockets? How does it affect us with economy, this COVID? We hear of the crude oil going down. How does that affect us? And we as men, as priests of our house, of our household, how does it affect us? as men. So that will be the next topic that we'll be looking into, and we'll be having someone who's coming from the financial sector to answer that pertinent question. And then we'll have some people who, of course, who are having their own businesses, and they will share their stories as well as to how this pandemic also affected them with their business. Dr. Kota, over to you.
Thank you so much, Tsepiso. I want to take this opportunity to thank our pastor, Pastor Alexandra, for this info that we received from you. Our specialist, Dr. Tawanda, Slobosam, Mologlokonukuyu. Dibulele everybody who is here tonight. It was very fruitful for me because I've done the test already, Muleki. I've done it. I'm over 60, but I've done it. It's worthwhile, guys. It's very important to do it. Don't wait until it is late. Thank you so much. Thank you to everybody. Thank you, Sepis, for guiding us, for leading us to these programs. It's very fruitful for us. We learn so much from you guys. Thank you so much. I think let me pray, guys. Let's close our eyes as we pray. Our Heavenly Father, thank you so much for giving us this opportunity to talk to you, to bring these people, your people, our pastor, Tawanda, Dr. Tawanda. Enkosi Thixo wethu ngelizwi lakho lokusifundisa, sivule Nkosi indlebe zethu, sivule Nkosi amehlo ethu sibone. Enkosi kuba uthume abantwana bakho bathethe ngokuhlanje. Nkosi kubantu abaze bazophulaphula le program ngokuhlanje, sandisele ukulazi ilizwi lakho. Sifunde Nkosi ukwenza impilo, siphile bomini bethu. Ekugqibeleni igama lakho silibonge. Thank you so
Amen.
Okay.
Amen.
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 Thank you very much, gentlemen. Thank you. See, we are well represented. There's the Eastern Cape. There's Philip Bosman, all the way from Suneka. There's Eastern Cape. There's Joburg. So we are well represented. Thank you very much, gentlemen.
Thank you,
for
Sir
joining us.
Christo.
So we will send out the next poster in terms of the. So if you feel that there's a topic that you'll also want us to discuss, please let us know. You know the committee. Let us know, then we can surely make a way that we discuss whatever topic that affects us as men. Yes, how about the Eastern Cape is here?